didn't say any of those things because they are irrelevant. I'm also a very good actor. I act like I know things. I just borrow from the people who really know. I am Wangare. I am a civil servant. The rest, Kizungumiki. I don't know if this is necessary after that clip, because maybe we really just need to spend some time learning definitions, terminologies. We have, okay, let's make it. Next slide, please. So I'm going to attempt to define universal health coverage, and I'm going to attempt to differentiate it from NHIF. Lesson number 1, NHIF is not UHC. UHC is not NHIF. NHIF could be a component of UHC. As I said, could be. You can choose any other, right? So universal health coverage is about access. Access has many components, whether it's physical access, whether it's financial access, whether it's cultural and social access. Those are the issues of access that we're talking about. You can access health care. See, this health care can be accessed at home. It's not necessarily about accessing a health facility. Yes? The health services that you access must be of sufficient quality. Quality is another very long definition. Quality can be the inputs, that there are drugs, that there are doctors, that there is a theater, that there is blood. Quality can be the way the nurse talked to you. She can have been rude, she can have slapped you a bit because of the because you jumped the line, because she had a bad morning. So quality has many components, but this has to be balanced out, yes? So there are the structural components, there's the process components, and there's an outcome component to quality. And the last component of UHC is financial protection. This is the one I think most people resonate with, that whatever the cost of the health services, whether you pay at the point of care or you prepay in form of taxes, whether they're direct taxes, indirect tax, from your payroll, from when you buy bread and you pay, how much is bread? 54? 8 bob. 8 bob is the VAT you pay on bread. And that VAT eventually may get to health or to whatever else we decide. Financial protection is what most people resonate with. So you can either buy insurance, like NHIF or any other private medical insurance. You can belong to a medical scheme. Very many chamas nowadays have some sort of medical scheme. Many social welfare groups have medical sort of covers. You may have arrangements within your family when someone is ill, kila mtu anatoanga 2K. That is some sort of financial protection towards health, yes? I'm really just trying to break it down to everyday business. It doesn't mean that we are not paying for health. We are, in our very many social contexts, but there are more formal arrangements that have their advantages and also disadvantages, as we've seen from the clip. Next slide, please. So this is, I don't know if this is necessary, but I'll make a mistake. When we're talking about UHC, there are several dimensions of coverage we need. So let me be specific first. The universality here is about everybody. It's not a private members club. It's not if you pay, you access. That's not UHC, which is why I say NHIF is not UHC. Because you only access NHIF benefits if you pay. If you don't pay, you don't access. Right? That's more of what we have of private members clubs. So when you're talking about universal health, a country achieving universal health coverage, it's that everybody is in. Everybody. Everybody. You have everybody. Everybody. Not those who pay, not those in the formal sector, not the poor only, not the vulnerable only. Everybody. So the universality here is that everybody is in. And what we're talking about then in terms of dimensions of coverage, that's this, yeah? Breadth of coverage, who's insured, and we're progressively moving this way. So when we start with free maternity services, that's only the pregnant women who are in, or women of reproductive age group. Yes? And then if you talk about free services for children who are under 5, that's also another subsection of the population. So we are progressively moving this way towards 100%. That's where we want to be, that everyone is in. Once everyone is in any country in the world, these are the number of services that are covered. So we have maternity, we have some surgeries, we have some x-rays, we have chemotherapy, radiotherapy, and you progressively move this way to fill the queue. in any country or in the world, any country in the world, this dimension is not full. Any, I dare you check, this dimension is not full. But this is where the technical experts come in. How do you choose what is in here? You can start with the cochlear implants, you can start with the heart surgeries, and I'm not trying to say there's some diseases that are more equal than others, but it's a decision you have to make. That you're able to cover the population that you have as adequately as possible. So these are the types of services covered. And then the last dimension is how much do you need to pay from your pocket for these services. And this dimension, you want it to be as low as possible. That at the point of care, you pay as little as possible. And you have prepaid for it in advance. So the dimensions of university, I'm not sure if that information is useful at all to you, but I've given it to you. Next slide, please. So I think this is more the really important one, yeah? That we understand UHC, universal health coverage, in the context of what an entire health system looks like. This is barely legible to you. But I'm just trying to describe to you that beyond the financing in health, there's the access to quality medicines, there's the information systems, there's the health workers that need to be there, there's leadership and governance. And all these things must work in concert, must work together, not in isolation. You can't have finances without information systems, without drugs, and you expect adequate health coverage. You can't have one without the other. All must be present, working in concert. I'm not going to ask you what you think is missing. I don't think that's for today. But there are some school of thoughts that this is still incomplete. If there's one thing I want to leave this stage is that UHC is not just financing. That's only one of the many things we need to solve. Yes? Next slide, please. So I'll highlight one example which I think may now be unnecessary because Spotlight on Equity Issue 9 in our booklets has really done a very good job on it. I picked one example of a resource in the health sector, Human Resources for Health. And I'm just going to show you how our system is set up, either to solve equity or to propagate it. It will be up to you to tell me at the end. And then you tell me how you're going to move forward. So Human Resources for Health. I'm basically just going to explain this in 2-3 slides. Yeah. So health is devolved. It's a fully devolved function. The purpose of devolution is to enhance equity, right? To make sure that each county can get what they need, get the health workers that you need, right from the community level or up to the subspecialist level. So health workers are now hired and trained by county public service boards. Make an application, you are employed either on contract, permanent and pensionable, temporary, whatever terms that you agree on. It is then, therefore, the prerogative of the county to further your training as a health worker. The Public Service Commission scheme of service allows for medical doctors, I'll focus on medical doctors, to pursue further training after serving for 3 years in total in the public service. A minimum of 3 years, that includes your internship, so 2 years after internship, after which you can apply for paid study leave to go and further your education. You can get a yes or a no, you don't have to go, but you can apply for school. Yes? Next slide, please. So after internship, you have a pool of doctors for employment, right? Next. And if I'll just give you the example of how payrolls would look like. We would have, next please, doctors moving from this pool, next, from this pool to working in the county. So after you finish internship, wherever you did it in the country, you're in a big amorphous pool, and then you move to whichever county, and then from here you can move to doctor in training after 3 years. Now by training I mean you then therefore go and specialize. You become an obstetrician, you become a pediatrician, you become a surgeon. Now those trainings take a while. They take a minimum of 4 years up to 6 years. I'll take a random poll here. Who wants a surgeon who was trained for 1 year? 2 years? 5 years? That's the one you want, eh? You want the one with 5 or more years experience, yes? So you understand why the training takes so long. You don't want a half-baked specialist. So they go away to school. School in Kenya is Kenyatta National Hospital, Moi Teaching and Referral Hospital, or Aga Khan University Hospital. Or you can go abroad. You go away to school, and then at the end of your training, you come back. But you come back now as a specialist, yes? So fast forward to where we are now, and they still have a pool of doctors for employment who should be moving to work in the counties, and then from here move to training. But because this bubble has been growing, as you can see, this bubble is not growing. Who can guess why? Any idea why? Where are payrolls held? Payrolls are held in the county. Is there a structure of how a payroll must look like, or a county health budget? Let me put it that way. What is the ratio of development to recurrent? 70 to 30. Where is payroll? Development or recurrent? Recurrent. So can this pool in theory continue growing? Are we getting where the problem is? This is a fixed bubble. Yeah? If you have money for 100 doctors, you have money for 100 doctors. So if they all go away to school, they go to Nairobi and to Eldoret and to abroad, then you have fewer and fewer working in there. And then therefore they have less and less money to hire. So you'll find, next slide please, this is Bomet. Bomet's payroll has 80 doctors, but only 24 in the county. The rest are serving other governors for free. Next slide, please. This is Machakos, has 196 doctors in their payroll. Aren't they doing well? They've hired doctors, no? But where are the doctors? Next slide, please. I didn't want to show you the one for the strike because someone said, yeah, I'm a doctor. You'd have seen me somewhere there. Are we seeing how we are basically structured, unfortunately, to propagate inequity? The county is supposed to be doing the right thing, and some of them have made an effort, and you will see in this document. Actually, some counties where you have more specialists than you have general practitioners, they'll come back now as specialists. The surgeon will not see people in outpatient. The obstetrician will not see people in pediatrics. So you have doctors, in theory, you have propagated equity, efficiently or not. So in health economics, we have this struggle, or whatever we call it, a trade-off between efficiency and equity. It's not believed you can achieve one and the other at the same time. Every time you achieve efficiency, it is believed you give up equity. And this is a situation in which, in the pursuit of equity, we have lost both equity and efficiency. Have I introduced more questions than answers? Yes. Good. That was the purpose of my keynote. I was told 3 questions. Thank you very much.
The only reading I'm doing tonight is issue 9. My friends, I need to come back with some knowledge on what's going on in the counties and how the evolution has impacted budgeting for the distribution of health workers in Kenya. How many have learned something new from that presentation? Because I know I have. I definitely know I have. Our next speaker is going to make it a little bit more complicated for us because of how long they've been working in financing, health financing. Dr. Eben Barasa is the director of the Nairobi program of Kemri Wellcome Trust Research Program, and he also heads the Health Economics Research Unit of the Kemri Wellcome Trust Research Program. He is a health economist with 13. Are you as afraid as I am? This technical language is about to go to the next level. He has 13 years of practice, and and research experience in health economics and systems, with research interest in health financing, equity, efficiency, priority setting and resource allocation, costing and cost effectiveness of healthcare interventions, the economics of hospitals, and healthcare system governance. Dr. Barasa's presentation will present an assessment of Kenya's progress towards universal health coverage over a 10-year period. He will examine the progress made in coverage of essential services and financial risk protection, and he will consider inequality in the coverage. The implication of inequality in these dimensions of UHC will be explored, as well as potential recommendations for ensuring that progress towards UHC in Kenya is made fairly, which is the key word for the day, fairness. Help me welcome Dr. Edwin Barasa.
So good morning, everyone. So I don't need to say who I am now that Vivian has spent a considerable amount of time talking about that. So the discussion today is going to lead on from Wangari Ng'ang'a's presentation about universal health coverage and fairness. And part of it is going to be a repetition. Part of it is going to be a repetition, which I don't think it really hurts, but we'll try and go as fast as possible. So we've already talked about what universal health coverage is, and the summary really is that if someone needs a service, not if someone wants a service. It's not about the services that you want, it's about the healthcare services that you need. If someone needs a healthcare service, they should be able to access it of good quality without getting into any financial problems. So if you need a healthcare service, it should be available, it should be of good quality, you should be able to access it and utilize it, and you should not get into financial problems. That's what universal health coverage is. Next slide. And universal health coverage has a number of goals. So the first is access to healthcare services. And of course, there's quite a range of healthcare services. We've talked about it's not just about access to services in a hospital, it's really about access to the entire range of services that you need. Next slide. The other goal of universal health coverage is what we call financial risk protection, which is a very, big and unnecessary word for basically saying that when you access a healthcare service, it should not interfere with your economic situation. It should not interfere with the economic situation. So you shouldn't have to, for example, sell your assets. You shouldn't have to, for example, forego your food. You shouldn't have to, for example, forego paying school fees because you have to pay for healthcare services. And it has been shown time and time again that when the health system is structured in a way that you have to pay out of pocket, and you pay out of pocket at levels that interfere with the economic situation, then it can actually push you into poverty. So there's quite a number of people in low and middle income countries that are pushed into poverty, are meant to become poor simply because they have to incur financial expenditure to access healthcare services. How many people know of people who've been put into trouble because of healthcare bills that they had to pay? So we all know of stories like that, right? So what you're saying is that if, as a country, you want to move towards universal health coverage, you have to move the health system to a position where it is not responsible for interfering with people's economic situations, and it is not responsible for making people poor. So that is the second goal of universal health coverage. Next slide. And the third one, of course, is that as we ensure that people have access to services, we ensure that people are not pushed into poverty or are not, their economic situation, their financial situation is not interfered with. We have to do it equitably. So it's not just about expanding access to services, it's not just about expanding access to what we call financial risk protection, it's about doing it in an equitable and fair way. So that is an explicit goal of universal health coverage. So when we talk about equity, universal health coverage is at the center of that. it embodies the concept of equity, that we must do so in a fair way. We shouldn't be trying to protect the rich only, or we shouldn't be trying to protect women only, or men only, or the elderly only, or a certain race only, and so on and so forth. It should be everyone. So those are the 3 explicit goals of universal health coverage. Number 1, let's not get into financial trouble. Let's not get poor. Number 2, let's have access to the services that we need, not the services that we want. And number 3, as we seek to do that, we must do so equitably. Next, we've already talked about this. Just next slide. So the idea really is that to move towards universal health coverage, there are 3 things that a country needs to do. Because it is a journey. And the journey occurs in 3 parts. 1 is that you have to expand the range of services that citizens in a country have access to. So that is one of the journey that the country has to undertake. Expand the range of services. The second journey that the country has to take is to cover more people, include more people, have more and more people benefit from universal health coverage initiatives. And last, you have to reduce out-of-pocket costs. You have to reduce the amount of money that people have to pay out of pocket to a health facility to access services. So it's really a journey. It's about moving across, along those 3 dimensions. Next slide. And of course, we know that universal health coverage is a global health priority because it's a good thing. It's a global health priority. It's included as one of the key priorities that countries in the world are currently focused on, and that is the Sustainable Development Goals. And in the country, our president has made it one of his big 4 agenda. So it is a global priority, but it is also a local priority. The next slide. Now, we have said that universal health coverage is about moving along 3 lines. Cover more people, include more services, reduce out-of-pocket costs. Now, there is no one way of moving along those 3 lines. There is no one way of moving towards universal health coverage. So given that there are multiple ways, we also know that there are fair and unfair ways of moving towards universal health coverage. You can move towards universal health coverage in a fair manner, and you can move towards universal health coverage in an unfair manner. And what we want is a situation where we move towards universal health coverage using fair trajectories in an unfair manner, in a fair manner. Now, why are we concerned about making sure that we move in a fair manner? It's because of a number of reasons, and I'll highlight only 2. Number 1 is that we have the key constraint is that resources are unlimited. And this is not something you learn in university. This is something you actually learn in primary school, in business education, scarcity and choice. You remember that? That resources are limited and needs are always unlimited. So you have more needs in a country than available resources at any one time. So within the health sector, you will always have more healthcare needs than the resources that are available to provide for those healthcare needs. What does that mean? It means that a country has to make choices. At any one time, a country always has to make choices about what services do we provide to our citizens. So these choices always have to be made. And as resources become more and more available, then more and more services are added or included. And so the question is, how do you decide? How do you make a decision about what services to include? And how do you progressively make that decision as you're adding the services? And again, there are fair and unfair ways of doing that. And I think we'll have a bit of that discussion much later in the day. Now, the other thing is that universal health coverage is a journey. It cannot be achieved overnight. Okay? It cannot be achieved overnight, which means you have to achieve it progressively. So if you're going to achieve it progressively, then you have to progress in a fair manner. You have to progress in a way that does not leave does not discriminate against people, does not leave certain groups behind and takes forward other groups and so on. So that progress has to be made fair. So you can skip this. So we're talking about fairness, we're talking about equity, we're talking about inequality, and what do all these big words mean? They're actually not big words. It's quite straightforward. Inequality is about quantities. Inequality is about quantities. If one quantity is higher than another quantity, then that is unequal, that is inequality. It's as simple as that. So if I have more money than you, there is inequality in income. If I have more food than you, there is inequality in income. If I access more health services than you, there is inequality in access, and so on and so on. So inequality is simply about differences in quantity. Now, equity is slightly different. Equity is related to fairness. Equity is about when, if those differences or those inequalities are justified or not, or if they are avoidable or not. So for example, a child takes less food than an adult. Does that mean there is inequity in access to food? It doesn't mean that, right? Because their needs for food are slightly different. Someone who has chronic disease, for example, or a long-term condition, will be required to go to a healthcare facility more frequently in a year than someone who does not have a chronic disease. So if you count how many times did you visit a health facility, the person with diabetes or hypertension would have visited more times than the person without diabetes and hypertension. That is not inequity. But when you have two people and one has more access than another, simply because one is richer, or one is of a different race, or one is from a different geographical region, or one is of a particular gender, then that becomes inequitable and unfair. And that is really what we are concerned about. We are talking about those differences that are unfair and are avoidable. So that is what inequity or fairness is. Now within the health sector, we interpret inequality or rather inequity in certain ways. So one of the things we are concerned about is inequity in health and healthcare. And here I've already talked about the fact that when you have differences in health that are unnecessary, differences in health or access to healthcare that are unnecessary, then you have inequity in health or healthcare. Now we are all